Yes, so now talking about new epitopes and T-cell enrichment, um, I would like to introduce the next speaker, and it's my really big honor because the next speaker, Rolf-Dieter Issels, was my PhD mentor in Munich. So we met 25 years ago, and we starting on immunology. And so it's fantastic after 25 years to keep the friendship, the loyalty, and also the research together. So Rolf Issels, thank you for coming. It's a big honor coming from the Ludwig Maximilian University, the Hospital Großhadern, where I was a pioneer of establishing the role of hyperthermia in sarcoma. And this is, you will talk more about this, but even more exciting are the discussion and the scientific thoughts behind that, especially on the topic of immunology. So thank you very much for coming, Rolf.
Yes, works. Hello, good afternoon. First, I would like to thank the organizers to invite me to this very marvelous place. I've never been here, and I read in the history of the founder of this institution, it was really a eventful life. And it's really interesting. And I'm very happy and honored to have this invitation. I hope I can fulfill your expectation after this perfect previous talk on immunotherapy itself. I have a very complex topic which is dealing with hyperthermia. I don't know if it's very well known to everybody of you, but there is a growing interest in Switzerland in hyperthermia, which is remarkable. And it's based also on old stories, and I want to come later on this topic. Just to start, before I start with the immune effects, I start to give you a kind of overview on the clinically established, maybe I move to this place here, oh, I can see it here, the clinical established hyperthermia devices. We have some devices to treat local tumors. So what that means, local regional heating up to 40 to 43 degrees. We have for deep heating, I come to this point, we have two producers, Alba and Pyrexa. We are producing a radiofrequency device where you can treat patients even with abdominal or deep-seated tumors in this range of temperature, and you're controlling temperature by MRI techniques. Nowadays in Munich and some other places in Germany, we have 8 centers in Germany equipped with this type of deep heating devices. Then, of course, we have recirculating devices, which is here for bladder cancer, Synergo or Sensius for head and neck. And then, very interesting, we have HIFU. And when we had a meeting with Philips in Eindhoven, I called them, this was done for thermal ablation, they should produce something which is low-fu. So we have a lower hyperthermia induced, and they are working on this. So what is the old story? I call this the old story. The old story is that hyperthermia, when you combine it with standard, complements standard treatment such as chemotherapy and radiation therapy in destroying tumor cells. And this is simple, this cartoon showing, and we are not knowing exactly what happens with tumor cell death. Ongoing interest is now in ferroptosis, which is a special form of tumor death. But we know that there's an apoptotic cell death and there's a necrotic cell death, and this has immunological consequences. What is the evidence? The evidence is just to give you a few examples, but the most important examples for hyperthermia. We have evidence in melanoma, cervical cancer, chest wall recurrence, recurrent breast, soft tissue sarcoma, which is especially our interest, I will show you in a moment, and non-testicular malignant germ cell tumors. Why I'm showing this, so this is not an obscure area of research. It has already entered the clinical research with very impressive results. And one of these this is now our contribution to the field, are soft tissue sarcomas. And if you go through all this list here, and even more on the right-hand side, you see how long it takes to make a real efficacy, a proof of efficacy in such a tumor, which is heterogeneous. And as we had a 3-year follow-up, 36 months, there was local progression-free survival after neoadjuvant chemotherapy. So primaries of tissue sarcoma were treated with 4 cycles of chemotherapy, and in the other arm with 4 cycles of chemotherapy plus hyperthermia. And after 3-year follow-up, 36 months, the local progression-free survival was the primary endpoint, was significantly better than the control arm. And then, what we could not explain, this was not a primary endpoint. After 3 years, we did a follow-up, a long-term follow-up, and it was interesting to see that survival now, overall survival, was increased by the addition of hyperthermia. And at this point, it was also interesting for us, astonishing, I would say, that we found the whole group has in survival a benefit. And this was at 27% reduction of the risk to die from this disease. But more important, it was interesting that also the extremity sarcomas, which are not dying from local tumor before you can amputate them, and this was in fact the standard of care 25 years ago. But the non-extremity abdominal tumors also had both subgroups benefited from hyperthermia. So even this trial in Germany led to the S3 guideline recommendation in June 22. So we have 8 centers and offering hyperthermia for this kind of patients, and this is accepted trial and reimbursed by the state government insurance companies. Now the question is, and now we're approaching a little bit this talk here, we have to ask the following question. How can it possible that a regional treatment combined with a systemic chemotherapy, when you compare it with systemic chemotherapy alone, leads to an improvement in survival? Any idea? The point is, we have to look for features associated with long-term survival in these patients. What happens with the immune system? And the reason for this is, and we overlooked this in the beginning when we published the data, you see a late divergence of survival curves resembling observations in immunotherapy trials. So after 1 year at least, there was no separation of the survival curves. And still, later on, you have this improvement, which I already mentioned, which was significant. And you see here, and this was seen in one cartoon of my previous speaker, in New England Journal of Medicine, when you use checkpoint inhibitors and progression-free or disease-free survival is analyzed, you see again this late divergence of survival curves. So this was, in fact, our first meaning maybe we should look a little bit in these patients what happens with the immune system. And you see here on this cartoon, I'm happy that my secretary puts it in, you see what is from cold to hot, very interesting, overwhelming. You have to include some of these pictures in the talk, otherwise it's boring. So the point was already mentioned by Valeria. And this is 150 years old, a year ago, where Cooley, with vaccines in patients who had erysipelas, which is a streptococcal infection, and they had high fever. And this was interesting. He was a keynote speaker in the academic science, and he gave as a surgeon this talk, and nobody could believe it, and he himself, he could not believe it and explain it. There was an infection, and these patients who had an infection do better in survival in sarcoma patients than without fever and infection. This was the first hint, but already Valeria mentioned this very nicely. And what are the hallmarks of hyperthermia today? Very short. We know from many trial and investigations and data blocking cell survival, sensitization to chemotherapy, I already showed you, changing tumor microenvironment. I come to this point now more especially, evading DNR repair. So any breaks, DNR breaks can be not repaired when you have hyperthermia, because we are blocking BRCA2 and other repair system, which is interesting, modulating immune response, of course, and inducing cellular stress response. And when you look here, this was now the hypothesis, some data, some not. And the idea is that radiation chemo combined with heat is killing tumor cells. And you heard before, it's very important how get the antigens from these tumor cells to the immune system. And you give now a local treatment with hyperthermia, and you destroy tumor cells. And the antigens, this is a simple cartoon now, are chaperoned by heat shock proteins, which are induced by hyperthermia, the HSP7 inducible form. And then these chaperoned antigens are presented to dendritic cells, the antigen-presenting classicals, and you have an adaptive anti-tumor immune response, CD8 cytotoxic T cells. Keep this type of cells in mind when I'm showing later the other. The other point was, we ask, is maybe directly by heat shock protein an activation of the innate immune system. So what you see here on this cartoon, and this is the take-home message, the new story is, by a local treatment, what is the mechanism to get a systemic effect involving hyperthermia? Now this is more, I'm not going in detail in this. Valeria is in some of these papers co-author, you know that, and they are highly ranked journals. We looked especially because we were completely dedicated to the HSP70. This was a hype. When I was in Boston in Harvard Medical School for 2 years, everybody was talking about heat shock protein and cross-presentation, and this is important for immune modulation. So we asked the question, HSP70 is of course induced by heat. Now we see NK activation. This is Gabi Multov's work predominantly, and directly HSP is activating NK cells. This was the hypothesis, or even the data preclinically at this time. And then the complexes are cross-presentations. And indeed, we found a priming of T-cell, adaptive T-cell responses. So all these papers, you can have the talk afterwards if you want to read some of these papers. And even now, there is a much more complicated story, because now we analyze also that the NKG2D, to just give you one example, on NK cells is a receptor, and the MIC-AB, which is an is a MHC-like component, has in its transcriptome a heat shock promoter sequence. So when you give heat, they found that this goes up, MIC-AB, and then you have the corresponding partner for the NKG2D, and you activate NK cells. So, coming to the checkpoint blockade. One thing is sure, and this I was not asking my previous speaker. We had a chance to talk 1.5 hours before the conference. What is clear is all the checkpoint blockade at the tumor sites depends on the presence of or infiltration of immune cells. So if you have not in the tumor any immune competent cells, they call it immune desert tumors, then you cannot expect that your checkpoint inhibitor is working. This is a very important message. So they have a list of tumors, and what Marsha Binder said, the highly immunogenic tumors are on the left-hand side. They have already tumor-infiltrating cells. But on the right-hand side, pancreatic cells, tumors, you don't see such infiltrating cells, or only very seldom. So the players are the Tregs, which are immune suppressive, the FOXP3 cells, macrophages, you have the tumors, of course, here, and then you have the T cells, or the PD-1, PD-L1. I don't have to mention anything more, because it was already in your introduction, that the checkpoint inhibitor deblock a blockade. And then you can activate these cells, but only if they are present in the tumor. Now, it's an interesting question now. We are using hyperthermia to heat up, and at the same time has a dual meaning. Can you make an non-immunogenic tumor to what we call as immunologists or clinicians call immunogenic tumor. And this is, of course, due by the immunogenic cell death. And what I promised you to show before was what happens in our sarcoma trial, the randomized trial. Now you see here that we looked for the immune infiltrates in this translational research program. And as I said, after 4 cycles neoadjuvant chemotherapy in 109 patients, we were able to get all the biopsies before and after. And we compared this with the neoadjuvant chemotherapy alone. And this is just saying randomized patients, but this was not a prospective trial. It was a retrospective analysis of the patients who were randomized, just to make this clear. And this, I'm not going in detail, but it tells you we looked for tissue microarrays for TILs, tumor-infiltrating lymphocytes, CD8, cytotoxic T cells, FOXP3, these are the regulatory immune suppressive cells, PD-1, PD-L1, and you see here a score for CD8 high-low, TILs high-low, and you see here some of the samples in this arm were 56 patients, and the other one 53 patients. Some of the samples were paired. In fact, 28 were paired, and the rest were unpaired. This is, for the analysis, very important. And we looked after 4 cycles, before and after. And since all these patients were resected of the tumor after preoperative chemotherapy, it was possible to get these biopsies after the 4 cycles. Now you see first, independent of treatment, before and after, we have a significant increase in the tumor-infiltrating lymphocytes, and of course we had to look for the paired biopsies, that was the same. Now also, and this was even more important for us, in the post-biopsies, post-treatment biopsies, independent of treatment, not separated NAC or NAC plus hyperthermia, we saw that the high infiltration in the tumor post was highly significant, associated with disease-free survival. And in the low TILs, not. And when we looked in the data, and you will see this, I tell you, if you can see it, high CD8 were 72% in these patients with high TILs. So logically now we ask for the 2 treatment arms, what happens with the high CD8? And you see here, high CD8 post, now separating the 2 arms. There was a highly significant association with high CD8, but not only in the hyperthermia arm, not in the NAC alone arm. And this was disease-free survival. And if you look for the low CD8, there was no difference, no statistically difference. Now, when you have a result, this was the first result I'm proud of. These are the first results in hyperthermia, in the context of hyperthermia, giving an evidence that there's something going on to make a cold tumor hot. Now, you always wait for another group of scientists, and this is done in AHK, Austria. And most recently, they published, Rupp et al., in Frontiers Immunology 23, and they had 21 patients with extremities of tissue sarcoma. They give radiation, and they have a radiosensitizer, which is ifosfamide, 6 grams per square meter, and they gave conventional radiation treatment. And what they did was, 21, they had paired samples. From each of these patients, even the patient number is small, you have paired samples before and after. And what they found, and this was of course very interesting for us, in the intratumoral T cell density, they found the CD3 T cells, which is a common T cell marker, but more important, the CD8 T cells, exactly the cells which I was describing before, were highly significant associated with disease-free survival, intratumoral, and also peritumoral. So we had confirmed results from another group using neoadjuvant radiochemotherapy before and after biopsies, and this is very important for us, and this gives us some evidence, even more evidence than that hyperthermia is inducing, in combination with any standard treatment, infiltration in immune cells. Now you see here on the forest plot, the risk of recurrence in these patients was absolutely predominant by the CD8 cytotoxic T cells, and in comparison to other tumor size, number of chemotherapy type of chemotherapy was negligible. Now the point is, when we, in this cartoon, showing you the hyperthermia, of course we know that by hyperthermia in this range of treatment, we have a membrane expression of HSP that has been shown before, but more important, we have an antigen presentation by HSP chaperoned. We have an antigen release because the dying cells release the antigens. We have recognition, and of course now the players with checkpoint inhibitors, it's very important to ask the next question, how this works together. And I should stop here. No, I have two other slides on it. Let's see, this is my important slide. I mean, in the end, I must say, to be invited here, and Valeria mentioned this before, it is for me I'm very proud of this, that some clinician with high experience in medical oncology is still keeping research activities and a strong interest in knowledge in clinical hyperthermia-related immune research. And I'm glad that we met Dr. Hübenthal. I'm very happy to have this conference here and participating in the conference, and thank you for the attention. Thank you.
So thank you, Rolf. I'm a bit embarrassed for all this gratitude. But of course, it's very nice to start an idea and then to see after some decades that this is coming into clinical practice. And if in a half work life, let's say you experience in the patient those changes, you will believe them, and then you will convince also the patients and the families that is working. So thank you for your contribution to research in general and to hyperthermia and its immunology. Thank you. Any questions? Yes.
Yes, I have a question. If I'm not mistaken, then Sweden prohibited hypothermia a couple of years ago. I know some immigrants from Sweden who came to Germany because of that. Can you comment on that?
In Sweden, I cannot give a comment on this because I was not aware of this fact. In Norway, they had a deep hyperthermia system. No, I can't tell you anything about this. Sorry.
Maybe the range of temperature is too big. I mean, making studies on hyperthermia is always a question of range. No? Yeah. So what is the step? Also when we do scalp cooling, for example, for reducing the hair loss, it's a question of range. How do you go from which temperature and acting on metabolism, etc.
Maybe I make one point clear. When you talk about 40 to 43 degrees, then you mean we have homogeneous heating of the tumor at one of these temperatures? No. You have, when you give all the equipment and you heat, we have now 18,000 treatments performed in Munich. It's always a heterogeneous temperature distribution. So you have low temperature at 39 degrees, and then you come up with 43 in 1 point. Just to make sure it's not an homogeneous heating. You have all these temperatures along the side. Yeah.
Yeah, you mentioned that hyperthermia might make a cold tumor hot. But sarcomas, I think, are hot tumors by themselves. They have a strong immunogenic activity by themselves. So if you think of cold tumors, would you think that hyperthermia would also be helpful in cold tumors like the pancreatic cancer? Do you have some data for that?
Thank you for the question. Usually you always say when you answer, thank you very much for the nice question, and you're completely right. I say the opposite. You said the sarcomas are hot tumors, they are immunogenic. All the trials, as long as I know, for these checkpoint inhibitors, they're both failures. There are only very, very few indications that sarcomas respond to checkpoint inhibitors. And one reason is that they have no infiltrates. So they are not hot, immunogenic hot. But this is just my point. I want to discuss this. The second point you ask is what happens with cold tumors. I strongly believe that hyperthermia is a tumor-agnostic intervention. More and more get the feeling we are doing an intervention which is not tumor-specific. We did a pancreatic trial. Now we do a gallbladder cancer trial prospectively. So it's interesting that all the time hyperthermia can do its job, and maybe also the immunotherapy job, without to be tumor specific. Nowadays we call it tumor agnostic.
Courageous.
Thank you. There are various mechanisms of hyperthermia. For instance, with radiation, it's DNA repair inhibition. But for the immunological aspect, you say it is the HSP70s, HSP90s that give the stimulation, the prime stimulation. My question is, are there other ways to raise this potential stimulations? For instance, a one-term radiation, so not a sequence of a daily fractations on once, and then keep the whole thing quiet in order to create necrotic cells to boost immunological priming.
On one of these cartoons, you are absolutely right. The radiation alone by immunogenic cell death induction, release of antigen is like an in situ vaccination in tumors, at least theoretically, hypothetically. But as far as I know, there's no randomized trial showing this kind of effect in a randomized trial. But your question was related to, is there immunogenic effect by independent of heat shock proteins? Is this your question?
Yes, or whether the immunological effect is aimed or caused by the HSP70s.
Okay, so what we did in the preclinical work over 7 years, which I showed you on one of these cartoons, preclinical data, this was absolutely dedicated to the function of heat shock 70 or 90. And this was triggered, I should say Pramod Srivastava at this time was in the US, and they published 10, 15 papers from the Hutch Center, and this was, everybody talks about heat shock protein is modulating immune response. Today, I'm a little bit hesitating because the induced form of HSP70 is clear, but the mechanism of immune activation is maybe different. So we are not, we see the player, but we forgot the trigger. And all these preclinical data were done without hyperthermia. It was just you buy the HSP preparation from the market, chemical market. And then you do your experiments. I like very much to heat cells and see what is the HSP70 then doing in the context of immunology, okay?
I was wondering how would the inhibitory mechanism in the tumor change upon hypothermia? So you nicely showed that hypothermia increases the infiltration of lymphocytes, but what about the suppressive character of the tumor? For example, does TGF-beta secretion change or adenosine secretion?
Absolutely, very, very important question. What I could not show here is that the Tregs, which we FOXPC we measured, go down to nearly 0 in both arms. So you have an effect of neoadjuvant chemotherapy alone as well as neoadjuvant chemo plus heat. The background of your question is the following: why, when immune suppression is going down, why the high CD8 cells are only acting in the hyperthermia arm, not in the other arm, because they are also high CD8. So the answer is, we know that now in the tumor microenvironment something happens what makes the CD8 cells in the hyperthermia arm active, but not in the other arm. And this we are looking for. These are the NeoSARC project we are now doing, and we do also now a prospective trial with checkpoint inhibitor, yes or no, randomized. But this is the background.
Okay, thank you.
Maybe I just wanted to add, there's also a question of kinetics. So the right technique with the right temperatures and the right time, because induction of immunogenic heat shock proteins is changing over time. So it's very important also the topic of fractionation, so you cannot give at any time. So you have to know that biology behind to understand when is the right time and then apply. Otherwise you will get into resistance, so that's the point. We have a question from Colombia, which is thanking Rolf for your talk, and he was asking if hyperthermia does kill the tumors alone, so without any combination, which I think is a very important question.
Yes, this was at the beginning of hyperthermia research. Of course, hyperthermia kills tumor cells, that's for sure. You can show it in clonogenic survival, and there's a dose-effect relationship. At different temperatures, you kill more and so on. It's very interesting. But when in the clinic, then in the animal systems, they did it. And they heated even sarcomas. They heated them alone with hypothermia up to. And what they realized was, very interesting, they get more metastatic disease. So there was a big shock. This was in 1980, 82. First data from animal data show more metastatic disease because from heat you also deliver cells outside of the tumor, and then you have the risk of metastasis. Later on, this was also in the clinic the reason why we never give hyperthermia alone. We always combine it with chemotherapy, even with low-dose chemotherapy, or with radiation. In none, I can tell you, in none of the centers worldwide, I was ever informed that the metastatic potential is increasing when you combine it with standard treatment. But it was very important because today, in the United States, there's one study running with radiation. They don't give any chemotherapy and they don't give a radiological center. They give only radiation plus checkpoint inhibitor plus heat. And another approach is checkpoint inhibitor plus heat alone in advanced cases. It's an open we don't have data, but hyperthermia alone in primary tumors I would never give.
In fact, also in Switzerland, it is approved in several entities, so agnostic, only in combination with chemotherapy, which is the case with sarcoma, or in combination with radiotherapy.
Yeah.
This is for a broad range of tumor entities.
Yeah.
So that's approval. Well, thank you very much for the discussion and this fantastic talk.